Thank you, Professor Prapan, and thank you for the invitation to come and talk to you. I am a bit daunted talking to you about this topic with the word success in the title, because I don't actually claim to come from somewhere that's done this successfully yet. I hope if I was asked to speak again next year, I would be able to report on the great success. But I think there is a lot of progress in a lot of places that I can usefully review for you. So as well as disclosing that I haven't yet succeeded in this area, I'll disclose these relationships. And I also want to say that today I'm pretty much going to be concentrating on PrEP in men who have sex with men. It's highly relevant in my setting in Australia, but of course very, very relevant throughout most of the Asian region. I'm going to talk about what we mean by success, whether we talk about the individual or the population level. I'm going to spend quite a bit of time on the study talking about our implementation project in New South Wales, the EPIC New South Wales study, and finish up with a few personal thoughts really on how we should be proceeding in this field. So, successful implementation at the individual level. The first thing I want to say is that I'm not going to do a review of the randomised trial evidence. I would hope that by 2016 or 17 now, most of us have seen those data over a period of 7 years now since the IPREX study. The key take-home message, particularly as it relates to men who have sex with men, that this prevention technology is virtually 100% effective if taken daily. So in adherent men who have sex with men, this is the most effective prevention technology we have, and I think many would now argue that there is evidence that it is more effective than condom use. I'm not suggesting it's an alternative, but that's the evidence. And demonstration projects now, so real-world projects which have started generally at a relatively small scale, also show that in men who take the drug, there is 100% efficacy. People don't get infected on treatment, and there's certainly now over 1,000 person-years of follow-up have been published, and there's a very large number of studies in the field at the moment around the world. Of course, the Achilles heel of PrEP is adherence, and that's why in the IPREX study we saw an overall efficacy level of only 44%, because many men in that study did not take drug as they were meant to. Since we now know that adherence is critical and that if you adhere you get 100% protection, the real-world studies, at least in the US, Europe and Australia, are showing very, very high levels of adherence. And many of these have been based on measuring blood levels, since self-reported efficacy is not always most accurate. There has, of course, or there has been one documented case of PrEP failure in all of these thousands and thousands of person-years of follow-up, and that was a Canadian patient who it appears was exposed to a multi-drug resistant virus. So as all medical therapies, this is not exactly 100% effective, but it's almost there. So it works. I mean, that's the bottom line, and we don't need to wait anymore for any efficacy trials. It is an extremely effective study. If we're talking about effective rollout, though, we are concerned with side effects, and we want to make sure that we're not harming people. And there are two areas where we know there are mild side effects. So, and the first of those is renal impairment. We're beginning to get a good understanding now that this is increased if people are older when they start PrEP. So certainly men in their 50s and 40s are at much higher risk of this than younger men. Borderline renal dysfunction at baseline as measured by low EGFR is certainly a risk factor. If there are other risk factors present, such as hypertension or diabetes, and if PrEP is taken daily as opposed to slightly less often, leading to higher blood levels and more renal toxicity. Generally, when this happens, people are stopped and it's completely reversible, and usually they can be restarted on drug without it recurring. So it is quite common that this leads to permanent cessation of PrEP. The other known toxicity of combination tenofovir FTC is, of course, reductions in bone mineral density. They certainly happen on PrEP as well. It's quite clear that it is measurable. It is again higher in those with higher drug levels, but again is reversible on stopping the drug. And as yet, there's been no suggestion that these are of clinical significance. But certainly we do need to keep our eye on these two things looking into the future. There's been a lot of talk about behavioural disinhibition in PrEP, and within the randomised trials, the data was relatively reassuring that that people randomised to pre-exposure prophylaxis did not increase their risk behaviour. But they were randomised trials where men didn't know whether they were receiving placebo or PrEP. I don't think it's surprising that we would expect an increase in risk behaviour, that's condomless sex, in settings where men now know themselves to be protected against HIV. And recent studies show that this is emerging quite strongly, that in fact there are increases in condomless anal intercourse. I won't say in risk behaviour because they don't lead to HIV infections. They do lead to STIs, but as long as the man is taking the HIV medication, they do not lead to HIV infections. So these are data from the large Kaiser Permanente study in San Francisco, just published a couple of months ago, on rates of gonorrhea and chlamydia over follow-up, and you'll see here the dotted line relates to urethral infections, a significant increase in urethral gonorrhea with time, and the solid line here referring to rectal infections, showing fairly substantial, significant increase in rectal chlamydia over time. This is, I think, a real effect. It's likely to be something we will need to deal with, but let's be completely clear, it does not lead to HIV infection, which is what we're trying to prevent. So that's at the individual level. I think, the argument is over. It's extremely effective. There is very mild and reversible toxicities, and there is a degree of behavioural risk compensation, but this doesn't lead to increased HIV risk. But what about at the population level? And I think this is very important, because when donors and governments want to invest in a new health technology, they want to know that it's having an effect at the population level. And by this, I mean, of course, reducing the rate of HIV infections in the population. And that means both in the people who receive PrEP, but also in the general population, because like a vaccine, pre-exposure prophylaxis, if it's rolled out to those at high risk, can have herd effects. And by that it means it protects the general population, because it disrupts patterns of onward HIV transmission. It disrupts the networks within which HIV is transmitted. So to maximise that population benefit, that herd protection, you need to be targeting a high proportion of people who are at risk of HIV, not just prescribing it here and there to people who can afford it or people who are very keen to be on it, but to be actively targeting a large proportion of the people at high risk of HIV. And if you want quick results, then you should try to roll it out quickly. Because just by ramping up over a long period of year, we tend to mask the benefit, the additional benefit that you get from PrEP. And then to measure the efficacy, ideally you need to measure HIV infection rates, which is of course not as easy as it sounds, because we all have, or most of us have, surveillance systems which monitor new HIV diagnoses, but they are a mix of infections that have occurred recently and of infections that have occurred a great many years ago. You saw in Dr. Nitya's presentation, the CD4 diagnosis in Thailand is now about 200, and that's on average 5 or so years after diagnosis. So we can't prevent this year the infections that occurred years ago. We can only prevent the infections that are happening this year. So numbers of diagnosis at the population level on its own is not necessarily a good measure of HIV success, and we need to have measures of recent HIV infections. So in talking about success here, I really need to say that as much as it works at an individual level, there is currently actually very little data that can really give high quality data on the success at the population level. And there's really only one place in the world at the moment that is San Francisco, that has seen large enough scale take-up of PrEP to inform this. And really, there's nowhere else in the world we can look at right now, there will be in a year or so, about whether PrEP has an effect. So I think it is probably too early to be talking about this at the population level, but that won't stop me having a try at it in the next few minutes. So in San Francisco, it's been estimated that according to the US guidelines, about 64% of HIV-negative men who have sex with men would meet the criteria for PrEP. This is based on the National HIV Behavioural Surveillance System, which is conducted roughly every 3 years in a number of US cities, including San Francisco. So the US guidelines for men who have sex with men are that you must have at least one male sex partner who is not, and you're not in a mutually monogamous relationship with an HIV-negative partner, and you report condomless anal sex or an STI in the last 6 months or an HIV-positive partner. So just for the moment, just focusing in this graph on the dotted line, which is the uptake of PrEP as self-reported by gay men in San Francisco in these periods roughly every 3 years since 2004. You saw by 2014 about 10% of gay men in the city of San Francisco were taking PrEP. Unfortunately, we don't have the data for the next snapshot, which I imagine is being done later this year. I hope it is, because they will be very influential data. But you can see even by 2014, a few years back now, 10% of gay men in San Francisco were taking PrEP. And so that on this graph is about here. PrEP, in fact, was it first introduced in San Francisco around 2012, initially at a low rate, but then in recent years very much higher. And San Francisco is one of the very, very few places in the world with quite rapidly declining rates of HIV diagnoses. And again, we really have to be cautious here, because these are all HIV diagnoses, some of whom will be people who have had HIV for a period of years, and some of whom have got recent diagnosis, recent infection. But nevertheless, this is very encouraging, in the order of a 40% decline over a 3-year period. This isn't, I certainly wouldn't claim that this is all due to PrEP. San Francisco is one place in the world which has progressed perhaps most towards the 1990 goals, or certainly right up there amongst places. So here I'll just take the opportunity to say that it is obviously very important that we view PrEP as part of the solution of combination prevention, and not viewed as an intervention on its own. When we look at country level, we see much less encouraging data. So these are the US data. The last full year is 2012 for male-to-male sexual contact, absolutely flat. In the UK, last year available 2015, flat. Perhaps the beginnings of a decrease last year. Those of you who are keen internet surfers might have seen this report over the New Year period of the largest HIV clinic in UK reporting a 40% decline in HIV diagnoses last year. I think we're going to hear a lot of individual reports from clinics that are starting to roll out PrEP. But I really would caution people that these are just data from one clinic. They're not even full year data, and again, they include all diagnoses, including those infected for years. So we really do need to approach this question of are rates declining in relation to PrEP with some methodological rigour. When we look in Europe as a whole, we see a dismal picture of increasing infection in sex between men. And when we look at Australia, Nithya showed you a very similar, she showed you the graph for New South Wales, Australia-wide, we've seen an increase in new diagnoses over a period of a decade or more, but a stabilisation in recent years. And these are mostly men who have sex with men. Of course, all of you are well aware of the frightening patterns in many Asian settings, and particularly in large Asian cities, of increasing prevalence rates in men who have sex with men. So with that background, I now want to focus in on New South Wales and talk about our strategy of ending HIV, which includes the treatment as prevention approach, testing more and treating early, but also prevention. And New South Wales has an urgency in this, in that we've said we'll do it by 2020, despite not seeing much of a decline yet. We are now approaching, this is the diagnosis and care cascade for Australia. We are very close to approaching the 90-90-90 goals, so that overall about 70% of people living with HIV in Australia are estimated to have suppressed viral load, but we're still not seeing a decline. We have a lot of buy-in into this equation of ending HIV in Australia, in New South Wales in particular, including by the community-based organisations. We learnt a lot from small-scale demonstration projects which started since 2014. From these studies across 3 states, we saw that with biological measures of adherence that we had very high levels of adherence. Most men who were at risk took the drugs. We did see very high rates of sexually transmitted infections, but we saw 0 HIV infections in about 500 person years of follow-up. And that brings me to the next step after those demonstration projects, the implementation project of EPIC New South Wales. So this is very much a study which is based on a public health intervention. The Government of New South Wales decided it would roll out PrEP, and the EPIC study is fixed onto that, if you like. It's a statewide intervention. It's not just a city intervention across many public and private clinics. And our co-primary outcomes are the incidence in the cohort and the diagnosis in the state, which we can divide into new infections and other. And our aim was to start in a 9-month period commencing on the 1st of March, all high-risk men in New South Wales on PrEP by the end of the year. And we keep the study as simple as we can for clinics. So who's high risk? We use data from our local cohort studies, and obviously if you've got these are a tremendously valuable source of information to define who's at high risk. And these include serodiscordant couples where the partner is not on treatment, people who have casual receptive condomless anal intercourse, rectal STIs or methamphetamine use. The government wanted to know how many of these men, and we are in a situation in Australia where we have very rich behavioural data available from behavioural surveillance, and we estimated roughly that there would be about 3,700 such men who would meet the high-risk criteria, and that those men would have an incidence of about 4% per year of HIV, so that with the known efficacy of PrEP, if we could start all of those men, we would prevent in a single year, that's a year after the study is fully recruited, about 150 infections, which would be a 50% decrease in diagnoses in New South Wales. Very, very highly ambitious target, but one which we believe is possible if we can target all of these high-risk men. So New South Wales, for those of you who don't know, is in the southeast of Australia. It's about 7 million people. We have clinics in the study all over the state. It's about 1,200 kilometres from our most southern clinic to our most northern clinic. We have recruited even better than we hoped. The treatment has been extremely popular among gay men. So these are the last publicly available data. By the end of September, we'd had 3,500. We've got more than 4,000 currently on study. As you can see from these data, they're almost all men. We do have a small number of transgender people and mostly gay and bisexual men. The age range basically reflects the epidemic in Australia. We monitor the region of birth and ethnicity of people because New South Wales is a highly ethnically diverse place, and we are a little worried that we're under-recruiting Asian gay men who form, so we're comparing the countries of birth of people on the study to the people diagnosed, and have been then targeting focused publicity through our community-based organisations at Asian gay men to try to increase recruitment amongst those men. We have translated study materials into the 6 most common community languages in New South Wales, including Thai, including Arabic, including Indonesian, Portuguese, and others. So why have we done so well or so quickly in recruiting? And I think it's a very, there's a lot of things that have worked in our favour, but the most important one has been high-level political support at the very highest level. The Health Minister has signed up to this target of virtual elimination of HIV, and it's treated with a real sense of urgency. And it's basically a deliverable for her that she's aiming to do that. It's of course not just the government, it is a formal, very respectful partnership between academia, government, community organisations and clinicians. So I put this photo up, which was celebrating our 1000th participant back in about May, this is the Health Minister, Gillian Skinner, there. She wanted to announce to the state. We've got the head of the largest community-based organisation, the Chief Medical Officer of New South Wales, if you like, the head doctor of New South Wales, a community member who's prepared, because the levels of stigma are relatively low, to be out that he's a PrEP user and to be available for press interviews. Certainly having a professional consensus among our HIV organisations that this was a good thing, that this was an effective intervention was utterly critical, and having the community involved at every step of the way and involved as a formal study partner. So we have ACON, our community organisation, at our weekly study team meetings. We troubleshoot with them. When we identified the relative paucity of Asian gay men in the study, it was ACON who devised ways of getting out into the community and recruiting those men. It certainly has helped us that Australia has a highly functional primary care system, because when we're talking prevention, we're not talking about hospital-based care, we're not talking about specialist care, we're wanting to devolve this as much as possible to primary health care, and that has helped us very greatly. And this has been a research study, and as such we've been required to provide drug-free to consumer, and that certainly has been a help as well. So of course when I present this data, everyone wants to know, are we succeeding in decreasing HIV? The short answer is it's too early to know, but the longer answer, which I've only got a couple of minutes to talk about, is that we're quietly confident that we're beginning to see real change. So these are data over the last 6 or so years by quarter in New South Wales. The last full quarter of data, which was the September quarter, was the lowest September quarter seen in more than 6 years. So it's promising. The data within that on new infections are even more promising, but we're holding our, we're watching these data closely, and hopefully we'll have more to show you soon. So in terms of measuring success, we obviously want to measure that we continue to have close to zero incidence within the cohort, and that is the case. We haven't seen anybody in the cohort to develop HIV, but we also need to measure sustained reductions in HIV infections in New South Wales. As I say, it's too early for me to comment, but I think globally, 2017 will be a big year for the emergence of data on HIV trends in cities and states which have really scaled up. So certainly some US cities are doing very well in this respect, but have taken a few years to get going. I think the unique thing about the Australian situation is that we started relatively late. It was 2016 when we started, but we've started with a very large bang. That, not only in New South Wales, but in Victoria and Queensland, so the populous eastern states, large-scale implementation projects are underway, which should enable us to measure population impact within the next 1 or 2 years. So I want to complete with a few, finish with a few personal thoughts. You know, it really is time for us to stop arguing about when, where and how. We just need to implement PrEP for men who have sex with men now. If we're doing demonstration projects, they should be large-scale demonstration projects. Wherever they're done, this works as long as men take the drug. San Francisco is beginning to show us what is possible, really big reductions in diagnosis, and we don't need to wait anymore to do the implementation. So how do we do it? I think we really need, as scientists and clinicians, to tell our public health officials how effective this is. PrEP is the most effective HIV prevention intervention for HIV-negative men who have sex with men. It's better than condoms, as hard as that is for us to say. It's more effective. We need to centrally involve the community and primary care. This cannot be run by hospitals or by specialists. We need to really get out there to the community and primary care and really work in making the structures less complex. We need to work on reducing stigma so that people will present for treatment. And we need to work in developing this new, somewhat less complex workforce as in compared to treatment. I wanted to finish off with the final slide, but just thanking the immediate EPIC New South Wales team, but also the literally hundreds of clinicians in New South Wales who've upended their lives to implement this much PrEP this quickly. There weren't a lot of extra resources provided. It's been quite an amazing 12 months for our clinicians, but also for our community organisations who have retooled, they've decreased investments in other areas and focused this investment for PrEP while still promoting treatment as prevention and condom use for those who find it works for them. Thank you for your attention.